Ambassador Kapurji, please go ahead.
Thank you. Thank you very much. Yagya, it's so good to see all of you and meet you on this lovely day. Good morning, good evening, and good day to everybody. I am Pradeep Kapur. I am the advisory board member for the Wheels Global Foundation, where I'm leading the Smart Village program together with Yogesh and Lay. I graduated from IIT Delhi in BTech Electrical and then joined the Indian Foreign Service in 1979 and became secretary in the Ministry of External Affairs, Government of India. I have worked as ambassador of India in a few countries and also worked as a senior diplomat in many others. I've written quite a few books. The latest title, which I've written with Dr. Joseph Talil, Beyond COVID-19, Leveraging Technology for Better Healthcare, Envisioning a Better World by Transforming the Future of Healthcare, is a bestseller on Amazon. I hope you get a chance to read it. There are many lessons in that for the situation the world is facing currently. I also lead the Smart Village Development Framework for the Wheels Global Initiative. Welcome today to our webinar on public health policy and digital healthcare systems for dealing with pandemics. Since middle of last year, May 2020, when the pandemic picked up steam, Wheels has been very active, leading some of the best webinar series, a thought leader webinar series for the entire community across different countries. Wheels organized more than 25 thought-provoking webinars with industry leaders, with the common theme that when it comes to philanthropic activities, collaboration was paramount. Collaboration between NGOs, industry, government, local communities, and so forth. In 2021, our webinars have been more focused on implementation, program management, outcomes, measurements, and so on. Today's webinar culminates a series of 4 on lessons learned from the pandemic and the many policy implications. For those who might have missed the earlier 3 sessions on this subject, you can see the recording of these and our earlier webinars at our website, wheelsglobal.org, or on our Facebook page. You could also find them on YouTube under Wheels Global Foundation webinars. For those of you who are joining us for the first time, a brief introduction to Wheels and a refresher to the others who have been here with us on this journey on many occasions. Wheels Global Foundation is an initiative of alumni of the Indian Institute of Technology. Our mission: to offer technology-enabled solutions to scale philanthropy. We focus on the many challenges, such as facing access to potable water. So WHEELS is an acronym where W is for access to potable water, H is for affordable health care, E is for education, the second E is for energy, L is for rural livelihoods, and S is for sustainability. Where solutions do not exist, we encourage research and development at the IITs and at other similar institutions through sponsorship. We do work collaboratively with a host of partners such as IEEE ISV, Integrated Smart Village, CII, the Confederation of Indian Industry, Mission Samriddhi, Sarjan Foundation, Sevaks, spoken tutorials, and many others. We embarked on an integrated approach for smart village development, where we look at development of the rural areas in a holistic manner. And entrepreneurship is at the core of making these projects sustainable. In 2020, I am particularly pleased that both Niti Aayog and the Ministry of Panchayati Raj recognized Wheels Global Foundation as their partners for technology transfer issues for rural development. Throughout the year, we have had the privilege to share our experiences with both these entities, the Ministry of Rural Development of the Government of India and the Niti Aayog, Ministry of Panchayati Raj and the Niti Aayog. And this has helped to tune our own activities in the field also. I must add, we are a volunteer organization and depend on the generosity of our many donors who believe that scale can only be achieved by leveraging technology. This webinar series is made possible by a generous grant from Smita and Ashok Siddhanti of Andina Incorporated, an environmental health and safety consulting company based in Washington, D.C. A quick disclaimer: all the views expressed by the speakers in this webinar are their own views and do not reflect nor are endorsed by Wheels Global and its partners or its boards and its members. Some housekeeping messages. All the attendees are on mute throughout the webinar. You may ask questions for the speakers to the speakers by entering it in the Q&A box. In case you need any help, you can chat with one of us by raising your hand or typing your request in the chat box. You may also send us a question by email to info@wheelsglobal.org. A recording of this event will be available, as I said earlier, on our website, on YouTube, and also on Facebook. Questions from the audience will be curated and channeled to the speakers by myself, assisted by a beautiful and wonderful team of volunteers from Wheels. Today's webinar is culmination of the series of lessons learned, and we do have a very eminent panel of speakers who will now be introduced by the moderator, Mr. Rajat Gupta. Mr. Gupta, over to you. Thank you.
Thank you, Ambassador Kapur. Am I live? Can everybody hear me?
Yeah.
Absolutely.
It says start video. It says your video. Am I on video? Because it says you cannot start your video because the host has disabled it.
Yeah, we can hear you.
We can
No,
hear you.
but am I?
Please continue. Yeah, please continue while we try to set right the video.
Okay. All right. Is that working now? We can take this slide off. Can we take this slide off?
Yeah, it's working, Rajat.
Okay, great. Thank you.
Everything is good.
Okay, okay. I'll come back to introducing our esteemed panel in a minute, but I just wanted to make a few observations about what the state of the world and what has happened. Obviously, all of us realize that COVID has fundamentally changed all aspects of our lives. This combined with the existential issue of climate change calls for urgent action almost everywhere. One positive aspect, before I talk about the significant negative aspects, is that COVID has accelerated every desirable trend you can think about. If you think about, the digitization, or if you think about the idea of, e-commerce, if you think about the development of digital health, all of these things have been dramatically accelerated because of COVID. All the technology companies that expected their products and services to grow at a certain pace have seen dramatic increases in their revenues, in their profitability, in their reach, etc. But what is the fundamental issue that's being raised by COVID? Not only is it the health issue and the fact that we are under an very severe pandemic, the fundamental issue that has happened as a result of COVID and been accelerated is inequality. In every aspect, if you think about starting from life expectancy, of course, life expectancy has actually gone down, declined, but it's disproportionately falling on the underprivileged. Income gap has dramatically increased, again, at the detriment of those who need it the most. Even in companies, big companies, technology companies have all prospered, whereas the medium-sized companies, the mom and pop businesses have had a dramatic negative impact. If you think about all of us in this seminar, we're all privileged. Life has been very good for us during COVID. Of course, yes, we have had to be careful, but we're living in a bubble. We are protected. We live in nice homes. Our wealth has been growing. Stock markets have been rising. If you think about the physical aspects of it, nobody has to commute to work anymore. We do everything on web and Zoom. We are consuming enormous amount of Netflix and other entertainment. Everything gets delivered home. So in a way, we live in a bubble that if we were honest to ourselves, this COVID time has been pretty good. But that cannot be said for most of the world, and that cannot be said for the underprivileged. One thing that has grown is isolation as a result of COVID. I would say that those of us privileged don't even come into contact. We don't commute, we don't react, we interact with people who are underprivileged in any significant way, much less than we used to before. The impact on healthcare has been dramatic. All the weaknesses of the healthcare system have been exposed. Gap to access has actually increased. And therefore, urgent action is needed by all concerned stakeholders. This has, of course, been the topic of our previous 3 webinars on this topic. Many, many specific recommendations have come out, and I'm not going to go through all of them. It's a vast field. But at Wheels, we have focused on access via telemedicine to rural India. That's one of the signature initiatives we have taken. It's called the HEART model. You saw it in some of the exhibits. Healthcare, easy access for rural community via telemedicine. More than 300 centers in 7 states have been set up in just 3 months. We are rapidly on path to scale to 1,000 centers. That would mean 10,000 patients a day or more than 3 million a year. This has been a tremendous success, and we believe the impact has been exceptional, and I urge all of you in this seminar to please understand a little bit more, and if you so get moved, please contribute to take this initiative even further. Now let me come to our esteemed panel, and ask them to make their opening remarks. I don't think we need this page. I'm not sure whoever is controlling the screen. Okay. All right. Let me not. You see the first speaker. I'll ask each of the speakers to speak for 5, 7, 10 minutes, whatever they think they need, and then we'll open it up for discussions amongst the panelists, and I'll moderate it, and also to take in questions from the participants of the webinar. Arjun is a pioneer in the IT industry. He was co-founder of HCL, but more importantly, he's also been a serial entrepreneur. He has started many companies, helped many other companies. But most importantly, he is a philanthropist at heart and has given of his time and his resources without any questions asked. He has been, and I have personally experienced with him in the founding of the PHFI. He was a founding supporter. Also, I had the privilege of co-chairing with him the Pan IIT. So there is no other person I know who is as much of a giver as Arjun is. So over to you, Arjun, for your initial remarks.
Thank you, Rajat. That was very kind, and I think a little overboard, but thank you in any case. So I wanted to talk about healthcare, and I think we are talking about the policy and the interest. So I think let's talk about India. And the first thing you know, if any of you have been there or even visit or have the opportunity or the necessity to go to a doctor, is that doctors are very busy, even in the cities. And there is a general shortage of doctors in India. And so if we find them busy in the cities, in the villages, they just are not available. So, when you look at what's happening in India with the economy picking up, the number of people who can afford to come into the healthcare system is going up by some 10, 12%, some big number on a big base. And there is a shortage of doctors. Doctors are going up by some 6% or so. And if I need new doctors, I have to invest today. Then only I'll get the doctors 10 years from now. And while we are investing in India, not investing enough. And so that gap is going to go on and on. So if you're looking at doing something in healthcare, just remember that that is something that's going to be there for the next 10 plus years. So what we decided to do was to look at where doctors spend non-patient facing time and then try and see how we can use technology to reduce that so they can see more patients. The second thing this brings up is when I want people in a remote village to talk to a doctor, I can't use a standard telemedicine software because that expects a doctor or someone who knows medicine to be sitting behind the terminal waiting for this person to come on line and give their problems. That isn't realistic in India. So technically, if you're designing a telemedicine system in India, you've got to do it asynchronously. What you end up having to do is do it asynchronously, use AI to try and ask a lot of questions, try and capture all that, then try and give a diagnosis to the doctor so that when he gets it, the system has already tried to tell him what could possibly be wrong. He can disagree with it, obviously, he can go and talk to the patient. And that happens so very often. And then when he disagrees, through machine learning, you can update your system over time and make it more efficient. So that is one way of doing it. And we are finding that while it is happening in a lot of villages, as Rajat mentioned, there is a capacity even in hospitals for doctors to be able to do this. So we are still grappling with that problem in India. I don't know how many of you know that India is the diabetes capital of the world. 60% of the world's diabetics are in India. And it is also the world capital for not just blindness, but all eye-related problems, cataract, et cetera, and a fairly large percentage of the world's population is also of that. Those problems are also in India. So you're immediately presented with a lot of problems. The good news in India is the government has set up some very good infrastructure. We have an ASHA worker in every village. We have an Anganwadi worker in every village. And we have an auxiliary nurse midwife of 5 to 10 villages, depending on the population. But unfortunately, they don't talk to each other. Or they do talk to each other, but they have manual registers in which they're supposed to share information. And that just does not happen. And so again, there's a clear opportunity for technology to be used to enable them to become more efficient. So when you look at what the policy changes that we need in India, is we need the government to start investing in those areas. We need the apps, and there are lots of them available. We need the government to identify and decide on, and here we are lucky, unlike the US, where there are multiple electronic health records, and they're finding it difficult to, if you have an accident in Texas and your health records are in California, there's a good chance they won't even be able to read it because it's incompatible format. That in India, we don't have that problem. And so if we define it quickly enough, everyone will make their software on a standard format, and we'll be able to share that no matter where in the world you are. Especially important for migrant workers who come into cities from villages and then go back to the village. We need to have their data, digital data record that can be read. I think looking at that, the next thing is we have to motivate. Again, if you know how India is managed from a governance point of view, we have every district has a district health officer. And then you have people above them at 2-3 layers before they go to the secretariat or the mantralaya. And we need to motivate all of them, not have them just do their job because it's a government job, but actually, push them to provide targets and say how they performed against those targets so that we can improve that. I think there's a lot of work to be done there. The good news is states are starting to do it. They are actually implementing it. I know, for example, I'm associated with a project that addresses infant mortality and malnutrition. And after doing the proof of concept in Rajasthan, the state has taken the onus to push it through the state to all 33 districts. And, it's fairly effective. And we've now just started to work in 8 districts in Madhya Pradesh. And we're hoping that MP will also push it out. So there's a lot of work to be done. It's not impossible. There is a lot of groundwork that's already been laid, especially from an infrastructure point of view. I think we just need some policy decisions and a lot of technology and, of course, some budgets to make it happen. I think what COVID has done, as Rajat mentioned, is that healthcare never used to be top of the mind for a lot of people. Now it is really top of the mind. The government has, I think, allocated 23,000 crores or some big number like that to sort of strengthen the public health system. And people are also realizing that in a democracy, if you look after people's health and education, ultimately they're going to be happy and they'll vote for you. As I think Delhi is a great example where with the Mohalla clinics and them giving really good government schools to people, the present party was able to come back with a fairly large, a pretty big majority when they had their re-elections. And so people are seeing that these two things are making a difference, healthcare especially. And I'm hoping over the next few years, you're going to see a major change in this area in India. Thank you, Rajat.
Thank you, Arjun. Thank you. I think let's go to Professor Sarin. You can see his extraordinary bio right in front of you. I was amazed by 680 publications to his credit. That's an extraordinary number. He's right now, as you see, Vice-Chancellor and Senior Professor of ILBS, which is the Institute of Liver and Biliary Sciences. He was awarded the Padma Bhushan. for his many contributions to the field of health, widely published, widely recognized, and we are honored to have you. Over to you, Professor Sarin.
Thank you, Rajat. Thank you, Ambassador Gupta and all the team members. It's a distinct pleasure to be online with such dignitaries, and I would like to share some of my thoughts. Can you see my screen, please? Is that visible?
Yes.
Okay, so I bring greetings from the Institute of Liver and Biliary Sciences. I am a liver guy, and this is the only liver university globally, no conflicts. And except that we have very bright students, the lessons, everyone in India used to say, yes, we can do it, we have done it. I'm just trying to cover what were our missed opportunities or maybe lapses. Very bulleted. What India should have done during pandemic and beyond. And these are no criticism to anybody, but to myself. If I was there in some of the spaces, what I would have liked to do. We didn't have, in the beginning, indigenous, affordable, validated point of care diagnostics. We were getting it imported, trying IITs, trying everywhere else so that we could somehow get the diagnostic. Rapid antigen tests came in June, RT-PCR, few labs, 5 or 7, reliability. So the first wave passed in a manner that we didn't have enough reliable diagnostics. No question of being at the house or point of care. So this was something quite painful. Now even we don't have innovations coming up for the variants of concerns. We have to put up that machinery rapidly in order. As discussed by Arjun and others, and the whole mission of this webinar is about digital health and digital delivery of health systems. We had proposed several months ago to have a nationwide health facility registry. What does it mean? We give UHID to individuals. Can we not give a UHID to each bed? Each hospital has a UHID in which you have each bed. Oxygen bed, non-oxygen bed. Whether it is an emergency, whether it is pediatric. You collate that data, and I'm sure we can do it. Then we can share that data. We can audit that data, and if you have that data in form which can be collected rapidly, you can see what are the short-term effects. You say, oh, Maharashtra has so many cases, Kerala has so many cases. Okay, today it is short-term, but what will be the long-term effects? We have just closed our eyes, we have opened our shops and markets, but we haven't thought of long-term effects in those millions who have suffered. We still don't have our Indian protocols of managing these. We are learning, copying. What I want to say is we have to relearn all this for our own simple, low-cost protocols. And of course, the social and mental health of all ages has to be added. So I think the most important part, it's not just to go to small districts. We need to move forward with a policy maybe mandated by whichever system as a nationwide health facility registry. This is just to show you half of this is man and half is woman, but we can't make out unless you have some AIs in this. Well, decision making, it had always been totally centralized. Maybe 3 agencies, 4 agencies, 20 people, committees. It is not decentralized. I was going through how the plasma therapy came up in the US. It started with a small protocol from one of the hospitals in Washington. And the idea was you can all join, the whole country can join if you are agreeing to the same protocol. No questions asked, you just follow the protocol. But in India, you have to have X approval from Y person, from Y committee. You still don't have protocols approved for mixing and matching. So this needs to be decentralized. And the process must be that everyone becomes part of it. I had a talk with one of the chiefs in NIH, and they said, well, every week they would have 100 to 200 webinars during the stressful days. And everyone would say, well, we can do it. And our only job was to say, do it. Antivirals, efficacy, we don't know which antiviral is helpful for Delta, or is there any strategy to assess that? So I think what we have missed opportunities was, and priority was, to set up such a system which is participatory. And just now, I heard Arjun saying that, well, India is diabetes capital. Since I'm a liver guy, I must tell you, diabetes is a liver disease. If you have fat in the liver, you are likely to have diabetes. And all comorbidities, except for Hong Kong, nobody else gave importance to fatty liver and obesity. And 1 in 3 in the world has it. Just to show you something, much before we all came to existence in the Babylonian times and others, it was liver which was kept in the temples. All your horoscope was actually hepatoscopy. It is on the back of, this is your liver, this is your gallbladder. And this is the way every temple, every kind of predictions in life was because of this. I just added this because if somebody has fatty liver and 1/3 of the world has it, the COVID outcomes are worse and your vaccine efficacy is bad. But this was left out despite all my efforts. Anyway, for future, love your liver. Everywhere research hubs came up. Well, I wish India had 1,000, 2,000. Okay, here is 50 lakhs. Start your own hub. Give us something. But we didn't have it. We always had to apply. There was no free rain check. Okay, take it. If you fail, doesn't matter. I wish people like you can put up, okay, there is 500 crores. Try. We don't want to worry about wastage. Make India a country where research is a religion. There is no other religion. And ensure that pharma and industry are given respect. They're not looked down. Oh, they are only there to make money. Involve them from beginning in the formation of incubators. India lost those chances. Well, what is the effect of modeling? Because we were asking that IIT, this person, that group, we didn't have a platform. And the platform I mean is that you have a group of people whom you have collected for collecting data, cleaning, mining. That includes medics, technologists, economists, social scientists. We haven't till date defined. We need to do that so that health systems, at least for emergency and maybe for chronic diseases, can do it. And what is our aim? Is same. Everyone is talking of the same. Reduce infectivity, mortality, vaccine coverage to be increased, and economic, social, and mental health. We don't have models even today. One of the models developed in India used 260 variables. Last year, from Harvard, from Chicago, sorry, not Harvard, there was a model which used 36,000 variables. That was in Nature. We don't have people who put together that if you're coming out of your house and you're meeting or your kid is meeting, all that needs to be put into a model. So 36,000 variables, but you don't have a platform even today. Well, we need to think differently and break the barriers of all kinds. Let's do it today. You all are such gifted people. And Rajat, you can collect people, both IIMs, ISBs, and I'm sure Ambassador certainly can do it for us. Well, for vaccines, we are still struggling. People are doubting whether Indian vaccines are good in UK. We need a WHO approval. Had we done the proper processing, had we done and stood the test of all, kind of rigorous scientific scrutiny, no questions would have been asked. I'm not saying in any way I doubt their data, but well, maybe we could have done much better to convince the world. And even today, we need to do much more. We have to find still today how, if somebody has 2 dosages, what to do. Do we need a booster? We don't have mix and match studies available. So in my opinion, missed opportunities from last year are clinical trials and academic research to compete with the world. Just don't say we are good. We have to say we are as good or maybe better. Well, my last 2 or 3 slides are about rural care in pandemic. You all are masters in management, I don't have to say, but we haven't measured what is required in a rural setting. I heard about ASHA workers. I'll tell you what I think could have been and can be experimented. Your school is your hospital in the village. There are 5,000 people. Teach your teachers. There are 10 teachers. Teach them about infections, about health. Empower them to serve as primary health providers. There is a village, there is a central school, there is a tree under which they meet. Well, school building can be used as a COVID care center. We haven't done it. Then the teacher has an oximeter, maybe an oxygen. Everyone knows where to go. You call the ASHA worker there. She can refer people anywhere if there is a need. Therefore, health and education should be clubbed together, at least at the peripheral areas. Well, we need trained and ethically non-compromising students. Human resource is not just for medical, it is engineering, it is management, it is commerce, everywhere. But there were no exams. There was no assessment. And this is going on. I'm not against passing students. I'm not against the system. What I'm saying is, if we are doing this to our students, what will they do to their children? We should have ethically non-compromised students. They must know there is an assessment. They must know that, yes, we are all accountable to first ourselves, then to the society. And I think reflection is better than the original. All our aim in life is our students are better than us. My last slide is to say, yes, we can do it. We will. We need to look back and do introspection and be ready for the future. In what way? All over the world, you are connecting people. I think we must say not only India first, but India first and best. And it has yet to come. You all have a responsibility. And I would certainly like Ambassador Kapur to say, well, connect and show that anywhere. And then the wheels which you have started will move. Maybe our journey will be faster, smoother, and accomplished. Thank you for giving me this opportunity.
Thank you, Dr. Sarin. Thank you. Dr. Srinath Reddy. He doesn't need actually any introduction. You can see his extraordinary resume right in front of you. But I can tell you that from my own personal experience, I have to say that I have never met such an accomplished professional in almost any field that I can think of. My claim to fame was to convince Professor Srinath Reddy to become the head of PHFI, where he had, of course, a very promising career at AIIMS. He saw the vision and took the leap. But you can see from his resume, he is globally acclaimed, internationally very well known and published, a professor in many of the leading universities, including Harvard, awarded the Padma Bhushan. I can go on singing praises for Srinath, who is a dear colleague. So over to you, Srinath. Thank you for doing this.
Thank you, Rajat, and thanks to Wheels for this opportunity. I believe Wheels is essentially aiming at problem solving through barrier-breaking solutions which can be implemented to overcome the many challenges that India's health system has. So I'll try and open up some of the pathways for those solutions. But starting first with what are the lessons we have learned from COVID, apart from what the rest of the world has also experienced, India too has learned a great deal from COVID about the health systems in terms of what is needed to strengthen them. It is very clear that unless you have an efficient and equitable health system functioning well in the steady state, even without a public health emergency, we will not be able to build a strong and swift response when a public health emergency arises. I'm glad you emphasized the point about equity, Rajat, in your opening remarks, because not only we must be efficient in delivering services, we must do that equitably. And in both areas, we have seen lapses happening initially in the first wave and much more so in the second wave. Of course, there have been different states which have done a little better than other states, but overall, I think there is a great room for improvement. We also recognize that despite all the attention on tertiary care and ventilators in the first wave, it was very clear that it was primary care and secondary care which was most needed and most useful, because a large number of people could be treated at home or in primary care settings or in secondary care settings with oxygen. And therefore, the overdependence on ventilator-supported critical care units, while necessary, was certainly not going to be the central theme of response. It is also clear that what we need in terms of primary care is comprehensive primary care, which is continuous, capable of delivering both acute and chronic care, but should be connected to the other levels of care, the secondary and tertiary, in a bidirectional manner, in an efficient, seamless manner. And it is that connectivity which was absent even earlier, and this became also more clear during the COVID period, where people ran from pillar to post in many areas, and therefore the absence of a strong urban primary care system was telling. Even rural primary care, which was not that much challenged in the first wave, was challenged in the second wave, and the lapses showed up, and the connectivity issue also showed up. But we have also managed to find solutions. We now recognize that majority of the people could do well, whether in rural and urban settings, through supported and supervised home care. Majority of them do not need to be going to the hospitals, they can be monitored. Those who have a serious condition developing while on home care need reliable emergency transport and an assured admission in a tertiary care or an advanced care center. So it is the connectivity that was missing, which needs to be built up much more strongly. And some of this we have actually managed to try out in Karnal in partnership with Deloitte and the government of Haryana in the second wave, with point-of-care diagnostics and telehealth supported by emergency care transport for people who required. The whole package was built up. Ashas and Anganwadi workers were principally engaged. Auxiliary nurse midwives also came in. So the troika of the frontline health workers was engaged and also incentivized. But just to tell you what it achieved, if you look at what happened between the first wave and the second wave in the district of Karnal. In the second wave, the positive cases went up by 180%. The positivity rate, the test positivity rate went up by 240%. But the mortality, despite the fact that now it was much more dangerous Delta variant in action, went up only by 13%. And what was the difference? The supported supervised home care was 14.7% in the first wave. Actually, it was not even supported and supervised. In the second wave, with the introduction of these innovations, particularly with medical college students also manning the telehealth services, but most importantly, the frontline health workers much better enabled, home care was provided in 89% of the people. That means home care went up 7 times. And that had a remarkable effect on the clinical outcomes. And now the state of Haryana is scaling it up, Rohtak as well as other districts. The Niti Aayog wants to adopt it across India. And there is a great opportunity now for scale up of good models. We do also require training of primary care physicians, both in urban and rural areas, because it's not just the numbers that need to increase, the skill sets have to increase, and including for chronic diseases. We know, as has been stated, diabetes and a number of other chronic conditions are major factors in increasing the likelihood of severe disease and death in COVID. It's not just the infection that matters, but the associated health conditions actually tilt the balance. And therefore, even the detection of diabetes, hypertension, cardiovascular disease, cancers, liver disease, as Dr. Sarin has said, much of this can be done in primary care, and that requires training of non-physician healthcare providers who are technology enabled, as well as primary care physicians. And these are the kind of things that need to be supported. Mid-level care providers, whether they are nurse practitioners or community health officers, this is a big move now in order to ensure that the sub-centers are adequately staffed and even primary healthcare centers are adequately supported. The allied health professionals, the various categories of technicians who are required for primary care as well as for hospitals. There is again a great deal of emphasis now on ensuring that they are available in larger numbers. While production of doctors and super specialists at postgraduate level will take some time, we can actually start transforming our health system and the quality of care as well as the access to care by focusing a lot on the allied health professionals and the non-physician healthcare providers who are technology enabled. I believe we need to work with the state governments. This is one place where Wheels should be really focusing not merely at looking at the central government, but working with the states, because there are a number of progressive states who are interested in reforms and advancing healthcare in new directions, including telehealth services, digital health services. We also need to build public health expertise. There's a great deal of requirement of public health expertise right from the sub-center level up to the state secretariat level. And that is where even the government of India is now looking for more institutional growth for developing public health expertise at various levels. And that is something that Wheels could actually engage in. The whole area of supply chain management requires professionalization. And that is where, again, Wheels with all its industry expertise can come in. Quality assessment of health programs is again another area where the government of India is looking for assistance. A variety of health programs which require quality assessment, and including not only healthcare facilities, but even the programs. That there again, you should be able to come in. Apart from the Atmanirbhar Swasthya Yojana, which was announced in the budget and which is likely to roll out soon, which is going to bring about a fair amount of change in the primary healthcare systems and also connected to district hospitals. There is a great opportunity for capacity building and digital health. And that is where you should explore the opportunities. And also, the Finance Commission has clearly stated, and it's come into the budget, that now primary care funds will flow to local bodies, the panchayats as well as the urban local bodies, the municipal corporations. Where is the expertise there? We need to build up their sensitivity to public health issues bring in expertise for better management of health conditions, and support them again for digital health. So this is again a great opportunity for Wheels to step in. Therefore, I would say technologies for primary care, allied health professional training, digital health in different areas of health from primary to secondary to tertiary, but particularly to bring in better connectivity between the three levels of care in a bidirectional manner. Those are all important. Research is important, but I would stress on supporting implementation research. I think that is the most important. How do we deliver what we need to deliver with greater efficiency and equity? I believe what we really need to see also is a strong community engagement, supporting communities to become much greater partners in the articulation of what their healthcare needs are, in the design, delivery, monitoring of healthcare programs. So what we need is people-partnered primary care. And there again, Wheels can play a role in building community capacity. We also need decentralized, digitally enabled decision-making at block level, at the district level, at the state capital level, and central level with data linkages. And again, we require that level of decentralization as well for early response. And again, building in good data systems is going to be an important element where Wheels can come in. Finally, in terms of research, because Wheels now has multiple areas of engagement, it's not just health, but you deal with water, you deal with many other areas. It is that multidisciplinarity that is required because we are dealing in health as well as elsewhere with complex adaptive systems. And those complex adaptive systems can only be understood and addressed if we have multidisciplinary research. And therefore, in the area of implementation, particularly by designing better solutions, if you can engage all of the sectors that are required for health, not just looking only at the health sector as conventionally defined, but bringing in the other sectors relevant to health, then you can actually promote implementation research there and bring in a good placement for digital technologies in that area. And that's where Wheels can be tremendously transformational. Thank you.
Thank you, Srinath. That was extremely enlightening, and I'm sure we'll pick up on many of these themes. So let me invite our final speaker, Mr. Krishna Vatsa, who, of course, is an expert on disaster risk management. He has spent many years at the UNDP working on these issues. He's a career civil servant, became secretary level, and is now a policy advisor in this field of disaster relief. So over to you, Dr. Vatsa.
Can you hear me?
Yes.
Thank you.
We can't see you though.
Just one sec.
There, we can see you now.
Thank you. Thank you. So I would like to thank the Wheels Global Foundation for this invitation to the webinar. It's an extremely important deliberation, and it's such a privilege and honor to be part of this distinguished panel. And it's so good to meet you, Mr. Rajat Gupta, virtually. Thank you very much for your kind introduction. During my last meeting with the organizers, there was a suggestion that I focus on interaction of COVID-19 management with disaster management, as I represent the National Disaster Management Authority, NDMA, in this panel. So I would therefore speak on the issues which have emerged as critical from the angle of disaster management. The National Disaster Management Authority, of which I am a member, along with the state disaster management authorities, they are called SDMAs, and district disaster management authorities, which are called DDMAs, they constitute the system of disaster management system in the country. These institutions play a lead role in dealing with all the disasters. However, most of these disasters arise from natural hazards. So our experience in dealing with public health emergencies has been somewhat limited. COVID-19 represented a steep learning curve for us. As you know, COVID-19 has significant non-health dimensions and impacts. The most important of it were the restrictions that were brought on movements, services, and businesses, which we now know as lockdowns. These lockdowns were ordered under the relevant sections of the Disaster Management Act 2005. Never before the provisions of the Disaster Management Act been used so frequently and extensively in dealing with a crisis. So in that case, in that respect, it was the Disaster Management Act stood out as one of the most invoked legislative framework. In the beginning of COVID-19, there was a national lockdown that was ordered for 3 weeks, and it was extended further for another 5 weeks. So after that, there has been no lockdown at the national level. The decision was left to the states. The government of India would issue the guidelines, the broad guidelines for lockdown. Based on these guidelines, the states would start introducing lockdowns, introducing the restrictions, taking into consideration the severity and the spread of the pandemic. It was clear that the restrictions need to be brought about locally. Large-scale lockdowns at the national level are not feasible. Also, the implications of national lockdowns are difficult to manage. So what we saw that there were more dynamic models of lockdowns emerging, which are linked to the rate of positivity, the need for admission to the ICUs, and the case fatality ratio. Different states issued their orders of lockdowns and observed those restrictions selectively. Similarly, there were a large number of containment zones that were set up in various towns and cities, which were monitored very closely. These containment zones were supported through the deployment of a large number of health workers and police personnel. These containment zones were also set up and removed on a dynamic basis, derived from the spread of positivity rate, the spread of infection at the local level. The decision to set up and enforce containment zones was left to the district administration. One of the most important features of COVID-19 management was setting up what the Ministry of Health called war rooms. These war rooms, or integrated command and control centers, were set up at the national and state levels. Most districts also had emergency operations centers operational on a round-the-clock basis. The entire operation brought out the importance of setting up the fully equipped EOCs, or emergency operation centers, at all levels. While we are all familiar with the EOCs, there is a need to standardize these facilities across the country. EOCs are not just control rooms where we send and receive communication. They are an essential part of the decision-making structure. They must have the capacity for processing the data and information, supporting multimedia communications, and deploying emergency resources. As is widely known, we responded to the situation by investing in national capacities in testing the COVID-19 cases. We also built up capacities in producing N95 masks, PPEs, ventilators, medical oxygen, and a wide range of medicines as recommended through the clinical protocol. It was a mammoth task ensuring that these supplies reach all the states of India. Establishing a supply chain and setting up an inventory of these critical supplies emerged as the most important priority in the course of dealing with COVID-19. As our disaster management system functions in the country, we focus largely on supplies of food, drinking water, blankets, and basic medical supplies. Most of these things are locally procured and supplied. Building new inventories for COVID-19 opened new dimensions of disaster management. We are now more aware of the need to set up emergency warehouses and inventory management to deal with disasters. They have emerged as an essential component of our preparedness efforts.
So we are short of time. We'll have to request you to conclude soon. Sorry for the interruption.
Yeah, okay, thank you very much. So what I'm saying is that in the entire course of the COVID-19 management, we have learned so many lessons which must be reflected and internalized within our disaster management system. The most prominent of these lessons is that while national institutions can lay down the broad framework, it is the local level preparedness and response that makes the decisive difference. Further, it is critical to invest in disaster management systems through setting up EOCs, multimedia communication facilities, emergency warehouses, and larger inventories of essential supplies. Committed funding to deal with disasters and innovative financing strategies to deal with large-scale disasters are also essential concomitant of a resilient disaster management system. The most important lesson, however, is the inclusiveness of our disaster management efforts. The more diversified we are in terms of a skill set, the more collective we are in terms of mobilizing our resources, the more credible communication that we build with the communities, the more successful we are. And I think I have tried to lay down all the different areas of disaster management where we have intersected with COVID-19 management. And these are the areas where some external assistance, support, and incentive can really make a big difference. Thank you very much.
Thank you very much, Dr. Vatsa. I know that we have some time left now for dialogue and questions. I see that there is quite a few questions that are on the question board already. I could pick one or two of them. Let me start with one of the questions was to Dr. Reddy on the Haryana model that you talked about. It seems like it was quite successful. What are the plans of taking it out to other states or having fast adoption of such a system?
Thank you very much. This model has been presented first to the Niti Aayog, and Niti Aayog then subsequently suggested and organized a presentation to the Prime Minister's office, the Principal Secretary to the Prime Minister, Dr. P.K. Mishra, took the meeting. And it has been endorsed for scale up elsewhere in the country. Firstly, the government of Haryana is going to scale it up, but other states are going to be also familiarized with this model. There are opportunities to further improve upon the model. There are other technologies which can be introduced, but right now, since the second wave is at a pretty low ebb, this is being prepared for a possible third wave, but the training programs would be undertaken with the anticipation of any public health emergency, which can be handled in a similar manner.
Thank you, Dr. Srinath Reddy. One of the questions by Ron Mehta is directed towards, as you said, liver diseases. Dr. Sarin was a part of a risk factor in diabetes and other things. But the question was, if you go around India, you find in every remote village, lots of processed snacks, fatty snacks, which are junk food, as you might call them, available readily. And what is the initiatives that you or others are taking to ensure that there is awareness, education, and even regulation for these kinds of foods that do much damage in the long term?
It's a very important question, and I think our society needs to understand the the challenges, and 10 years, 20 years down the line, we will have a very large series of unhealthy youngsters. The junk food, or you can call it more carbohydrate rich rather than fat rich food, is the one which is causing all these changes. It's common to see people who are 90 to 120 kg, maybe 10% our population is in that range. It is for organizations like Wheels to create awareness, also to see that fatty liver is the core for all ailments. You have fat in the liver, the insulin cannot work. To get the energy required, more insulin is produced and you get diabetes. This fat travels to gallbladder to make stones, to arteries to have hypertension, to heart to have cardiac ailments. So a person who has a fatty liver has an inflamed body. Our messages are simple, and I must say, with the grace of God, India has become, in February 2021, the first country in the world to include liver into, and the fatty liver into, non-communicable diseases. It is the core to all non-communicable diseases. So India has recognized this, has come in as a Lancet publication on September 9th. What we need, and we do not have, I must admit, I need my friend like Srinath or so to take it to the masses, that the people become part of the movement and understand that for a good tomorrow, your today has to be better. So we have to stop this junk food or whatever you may call. It's not the fat, it's the high carb diet that we need to change. And if you reverse the weight, diabetes goes away and you are all right.
Srinath, you want to say something?
Yeah. Just to supplement what Dr. Sarin has said, but to answer the question about what is actually being done, the Food Safety and Standards Authority of India has introduced both regulatory measures as well as popular health education and nutrition literacy campaigns. The first one is it has imposed a restriction on the amount of salt, sugar, and unhealthy fats that can be put into a processed product. The only problem is small and medium industries are not yet in a position to fully comply. And street foods are going to be particularly difficult to regulate in that area. But there is a move towards extending the regulation as effectively as possible. It's still in early stages. At the same time, there is a major campaign that has been started called Eat Right India. It's not going to be purely in English language. It's going to be in multiple Indian languages. And that itself is also being rolled out. It was rolled out initially, and it was to go into the health and nutrition days in the villages as well. But unfortunately, COVID put all of that on the back burner. Now it's likely to be resumed in a larger way, both in urban and rural primary health care. So some measures are being taken, but a lot more needs to be done, as Dr. Sarin said.
I'm glad you pointed out that English is not the medium of communication to really want to get to health issues. And we have had, in Wheels, we've had an effort to do everything in vernacular, and we have had the technology available to be able to do that in what is called spoken tutorials, and that's allowed the widespread dissemination of all kinds of information, certainly related to health, in a much more effective manner. I want to ask a question about, I see a number of questions about digitization. I understand that Prime Minister tomorrow is about to announce a major digitization initiative in healthcare. Arjun, looking towards you, you mentioned the need that it needs to be pushed, but what do you see on the field, and how do you assess the progress we have made in terms of any of the digital health issues, whether it be personal health records or common standards, etc. Do you have a point of view on what you see in the field, and care to comment on it?
Yeah, so in one of the companies I work with, we have today some 8.5 plus million patient records that come in over time, and we're doing some NCD studies for different state governments to try and get that data for them. But, you know, the problem that we face, and I'm giving some generalities here, I don't want everyone to feel that it's specific to either them or anyone. We've noticed that doctors under the age of 35 switch to digital very quickly. Doctors above the age of 55 are very slow, and in between it's sort of 50-50. And so, you know, what we are doing is actually adding, they still want to write the prescription. And so we scan it. There's some very good technologies that allow you to take the scanned record and make it a digital record. But yeah, you're seeing that, and it's sort of normal because they're not familiar, happy with technology. But we find that they're willing to get an assistant working with them who can enter it for them. So that's the other problem in India is, I think there are kickbacks available from the testing labs to the doctors. And they're actually, I mean, that creates a different kind of environment because the minute I have it on a computer, all the data is available. So if you want to do an audit, it's very easy to do as to what happened where and stuff like that, which is also one reason why during COVID, a lot of states didn't allow us to do telemedicine in the states, because then the data would have been on a computer. And so you can't control what you're putting out in the press as numbers. I don't know whether they fooled around with the numbers or not. I'm not saying anything, but the fact that they said, they gave us that as an excuse, that they don't want to have the numbers on a computer so that they can be contradicted at some time, you know. So that's part of the problem. I think it's going away now. Everyone sort of realizes that it's important to provide better healthcare. Digital health allows you to do that. I can go door to door with a tablet and I can map everyone really in a village or wherever. And I think that's going to come up. It's going to happen slowly, but it's going to come.
One question I see, I didn't quite grasp the question, but it was in the direction of allied health professionals. Professor Reddy, you raised that question. How well are we doing on that front? And are they going to be accepted? I know that there are sometimes some resistance from doctors about accepting allied health professionals in entire healthcare or non-physician healthcare workers. What's your view on how we are progressing along that axis? I mean, you know, Indian nurses are well known all over the world, but I'm not sure that we have enough in India in terms of advanced nursing help who can actually take care of many of the issues that patients face without necessarily going back to the doctor. But your views on this whole topic of allied health professionals and non-physician health workers?
The term allied health professionals in India embraces a very large number of categories. And they actually have everybody from mental health counselors to optometrists to radiation technologists and X-ray technicians and so on. So as far as nurse practitioners are concerned, that is one category that's generally been accepted, and they are the people who have now been brought in mainly for being trained as mid-level healthcare providers. But initially, the government also proposed to offer a bridge course training to people from the Indian systems of medicine, the Ayush system. But that met a lot of resistance from doctors. But in terms of having other people trained as community health officers or community health assistants and brought in as mid-level healthcare providers, I think the question is more about the designation. Are they going to be sort of treated as doctors or as non-doctors? How will their cadre be controlled? How will they be supervised? Those are issues that are being sorted out. And I think in general now with the COVID experience, the doctors too realize that they need a lot more help. And having trained non-physician healthcare providers is going to make their life easier as well. So I think the resistance will break down now. But I think it's more the regulatory systems and the cadre structures that need to be defined, and these need to be defined at the state level. Each individual state has to decide on the policies there.
Dr. Sarin, you wanted to say something on this topic.
Actually, the last part, Dr. Reddy has already said. I just wanted to say that when there was pandemic, we required people who could look after ventilators, who could do transfusions, who could do testings. We needed people who have 1 month or 2 months training, but this was not available. This was not structured. And this should be in the domain of states and state health universities. Now, all these are by central, National Medical Commission or National Nursing, whatever it is, it's all centralized. So I think up to 3-year, 2-year degrees, maybe with the parent central agencies, but 1 year, 6 months, smaller trainings, which are emergency requirements, must be like you want to do ultrasound, you want to do echocardiography. All that is not recognized. So I think our paramedics need to be trained by state, and it should be decentralized and accepted. And these training programs are urgently required.
Dr. Vatsa, from an emergency relief perspective on a healthcare crisis as we faced, is this of concern and to you and your organizations about building up capacity in these areas?
Extremely important. You know, I completely agree with Dr. Sarin. This is one of the weakest areas of our emergency care system. We do not have enough number of paramedical workers. We don't have people who are trained in trauma care. And so our care in difficult conditions suffers a lot because we do not have enough people who are trained in this system. Our search and rescue teams, our first responders, they need to have much more training in this area. But what is more important is that we must have an established, well-recognized cadre of paramedical workers who can provide this kind of a care on a dependable basis. So it's an area which we must work on. Thank you.
Arjun, you were about to say something.
Yeah, I was just going to say that a little bit of field experience, and while yes, I agree with everything everyone has said, we have a digital stethoscope that actually can transmit sound and waveform, and you can detect heart murmurs remotely and stuff like that. And so it's very useful when you go to a remote village and give it to a person. I've had doctors object to the fact that a non-doctor was carrying a stethoscope around his neck. And that becomes, it's sort of, so you have to handle some of these issues which you can't predict till they actually happen. It's quite
in some states. In some states, doctors did not even want nurses to be officially permitted to give injections. So doctors will fight their every inch of the way. So I think they will probably.
It's a full employment. It's a full employment kind of insurance for them. Yeah, but leading back to this question, because it's such an important question, what do you see, Dr. Reddy, as one of the missions that you had in PHFI? You had the IIPHs and so on. Firstly, were they involved in, somebody asked the question, were they involved in this COVID response? And also, what is the role that these institutions can play in building up the capacity in different states?
Indeed, they were involved in very many ways, right from participating in a large number of governmental committees where they provided technical support, expert support, in doing actually field monitoring, in training mid-level healthcare workers, of course, but even in terms of ensuring that contact tracing was also being supported by our students who are under training with supervision of our faculty, and training of primary care physicians, not only in India, but also across multiple countries. We partnered with Research Information Systems, which is linked to the Ministry of External Affairs. and anywhere between 17 to 34 countries from South Asia, Southeast Asia, and Africa, primary care physicians in different training sessions participated for skill building and COVID management. So there are a number of areas right from primary care level, including, as I said, not only in Karnal, but elsewhere too. We have been working. Recently, we have also introduced new technologies for icon-based software where even data entry becomes very easy. Some of our public health technology developers in our institute in Hyderabad have actually launched the first drone delivery system for delivery of vaccines and medicines in government of Telangana the other day with Minister Jyotiraditya Scindia and Dr. Mr. K.T. Ramarao. So there are many ways in which we have been working, but particularly with governmental agencies to provide them support, but also working with a number of NGO partners as well.
Yes, can you hear me?
Yes, we can, Rajat, but your video is
great.
gone.
I have to ask now the chairman whether we are getting close to the end of the session and whether there is more time or we should conclude and move towards our closing comments.
Well, we have to move towards our closing comments because we'll soon be running out of time. So I'm going to take over from here, Rajat, with a very profound thank you to you. And I'll come to the other panelists later. Before I close the session, I have been requested by Dr. Raj Shah to make some points about the healthcare, which is being delivered along with Arjun Malhotra's, Evolko organization in India. Basically saying that traditional in-person healthcare is not easy during the COVID pandemic period. Therefore, remote healthcare using digital technology is one of the better alternatives. The tools which are required are the smartphone, medical devices, software, and cellular or internet needed by the 800 plus million villagers. There's nearer 900 million according to the statistics, living on less than $2 a day income mostly is hardly possible in India. It's one of the biggest rural population in the world. So the challenge is, how do we bring about digital healthcare to the doorsteps of these villagers in a very cost-effective manner? And the Health Council of Wheels, along with Evolko, have created this Pan IIT Alumni Initiative for healthcare, which Rajat mentioned earlier, the HEART model. Healthcare easy access for rural community via telemedicine, the HEART model. Wheels works with local NGOs and charity organizations and hospitals to select the village or a cluster of villages with an approximate population from 3,000 to 5,000. One male and one female village resident is selected and trained as telemedicine operator or a Sahayak. Wheels donates about $1,000 per center to buy the hardware, which includes a smartphone, digital medical devices, BP monitor, thermometer, pulse oximeter, glucometer, scale, weighing scale. The technology partner Evolko provides software, training, support, and maintenance. It also maintains a panel of more than 200 physicians to provide daily consultations. Patients pay a small amount of fees of 50 rupees. The Sahayak's fee of 30 rupees and software cost of 30 rupees. Of course, the patient fee is reduced with charity organizations pitching in or some other organization picking up that part of the cost. Thus, HEART model is self-sustaining and creates livelihoods for Sahayaks and support staffs. And the patients, in many cases, are served free of charge during the pandemic, particularly if they are the needy patients. Wheels has created more than 300 centers in 7 states in the last 3 months and provided care to more than 10,000 patients already and increasing every day. Wheels is proud to create this unique solution, which brings affordable access to digital healthcare to the doorsteps of the rural community. The impact: each center can easily provide care to 10 patients a day. 1,000 centers at a cost of $1 million enables care to 10,000 patients a day, 3.5 million patients a year. This is a very important aspect in terms of the bang for the buck. We urge you to donate and be part of this mission. Now, coming to my concluding remarks for the webinar today. First of all, thank you very much, Dr. Shiv Kumar Sarin, that you joined us in spite of such a busy schedule, which we all know about. Dr. Srinath, Reddy, the same, absolutely. Dr. Krishna, Vatsa, Arjun, Malhotra. And thank you to all of you for your excellent and insightful remarks and contributions to this important webinar. The comments on the chat box are also very clear in terms of the contribution and the enjoyment they had in learning during this webinar. Thanks to our chair of the Wheels Global Foundation, Mr. Rajat Gupta, a strategic and a visionary leader, for acting as a moderator today, sir. We appreciate that very much. Thanks also to the entire team of volunteers and collaborators who worked very hard to make this event a success. A link to the event today and the recording will be on our website, wheelsglobal.org, along with key takeaways from today's events, which have been compiled by Dr. Kavita Kapur. I'm sorry we do not have time to go through all those takeaways in detail, but please do read them on our website. There is also a donate button if you wish to make a contribution on the website, and the recording is also available on YouTube and Facebook. Finally, thanks to all the attendees, and we hope you will join us for our next conference. This is another path-breaking conference, is the Ideal Village Conference, which will be held over 2 days with a lot of participation from the Bay Area and other parts of US and India, which is being done by the Stanford University, hosted primarily by the Stanford University. They have an Ideal Village Center there, but this is being hosted in collaboration and in association with the Wheels Global Foundation. Mark your dates, September 28, 29, a phenomenal array of speakers again, like today. We have Mr. R.S. Sodhi, the Managing Director of Amul. We have Shri Shri Ravi Shankar, the world-renowned spiritual guru. We have Mr. Sunil Wadhwani of Wish Foundation. And of course, we have many participants from the Wheels Global Foundation. These include Suresh Shenoy, our president of Wheels Global Foundation, Dr. Raj Shah, who is leading the HealthCare Council, Smita Siddhanti, who's also a board member, and myself. We look forward to seeing you in a few days. Stay safe, keep well, enjoy the rest of the weekend. We will be running the slideshow, which we started with in the beginning, for those of you who missed out, so that you can get a chance to look at it again. And I will be circulating the entire contents of the question, answer, and chat, and the board, our team members, the IT members will be circulating the links also. So thank you very much once again, everybody. Look forward to seeing you on September 28th and 29th. Have a great weekend. Namaste.
Thank you. Thank you.